Which nursing action is appropriate in the care of a postpartum client to prevent fundal displacement? Okay, so the two choices that we came down to was ask them to void or perform a fundal massage. What could cause fundal displacement?
Full bladder.
Mm-hmm. Okay, so from displacement, we're thinking about if the fundus is not midline and isn't at the umbilicus, it's deviated. All right, and so this is going to be a full bladder. So if you have fundal displacement, if the fundus is deviated from the midline and above the umbilicus, massaging it isn't going to prevent that from happening. It's keeping the bladder from being full that's going to prevent that from happening. What's the big concern? Hemorrhage. The nurse is caring for a pregnant client in her second trimester of pregnancy. Which test will be used to confirm a diagnosis of Down syndrome? All right, so the reason that alpha fetoprotein isn't the best choice, why do you think? Any idea? The correct answer was amniocentesis. Why is that the better choice than alpha fetoprotein?
Well, the alpha fetoprotein says maternal, so that's the mom, and the amniocentesis is from the baby. It's like the fluid's the baby's. That's the way my
That's,
brain thinks of it.
and that's true, but so that is correct. But the key to that, to take it a step further from what Haley said, is that the question asks to confirm. Okay. And in order to confirm, it does have to come from the baby, right? Which is what her thought process is. So the alpha fetoprotein is what we can test for. And remember, if it is it high or low with Down syndrome? Think like low down. Okay, it's low with Down syndrome. If it's high, that can be an indication of neural tube defects. So that can be an indicator. If the alpha fetoprotein is low, that can be an indication of Down syndrome. That doesn't confirm Down syndrome. It is a possibility. So then let's say we have a mom, we check alpha fetoprotein, it's low. Then we might do an ultrasound, right? Because we can see some things on ultrasound that can give us indication of Down syndrome. Ultimately, though, in order to confirm, and that is the key word here, is to confirm, we'd need an amniocentesis. All right. So do you guys remember how we do an amniocentesis?
You use a long needle and like very ever so slightly puncture the sac and draw some of the fluid out.
Exactly. So that's super invasive. What kind of risks might be associated with that?
Rupturing the amniotic sac or infection.
Mm-hmm. Yeah. And so this is something that if you have a patient that has an abnormal alpha fetoprotein and then they do an ultrasound, they're like, we really think we need to do an amniocentesis. That's going to be something that requires a lot of education and really self-reflection, because that they could even lose the pregnancy with an amniocentesis, right? It has risks that go with it. So it's a more invasive thing, and we want to do least invasive to most invasive. A newborn is noted to be hyperirritable with tremors, have difficulty feeding, and notable yawning. What condition will the nurse associate these findings with? Okay, good. Yep, this is NAS. All right. You guys did really well with that. The nurse is collecting data from a female client who's in the third trimester of pregnancy and states the baby feels like it has dropped. Which term describes the baby settling in the mother's lower pelvis? Okay, so this, when the baby drops, this is called lightning. Okay, this is also when the baby engages. Do you remember engagement when the baby settles down into pelvis? Okay. Quickening, the term quickening, what does that mean?
Like
The
feeling the
little
baby.
flutters that you feel.
Mm-hmm. When does quickening happen?
16 to 20 weeks.
Good. Yep, 16 to 20 weeks. What's effacement?
Thinning of the cervix.
Yep, good. What's active labor?
Active labor. Just kidding.
It's active labor. What stage is active labor?
You mean like stage one, but it's like in the first part before like transitioning or something like that?
Okay, yep. So it's the first stage, and the first stage has latent and active phases. So it's the active phase of the first stage of labor. Okay, good. That's when we see most of our cervical dilation happening until we hit stage 2. And what happens in stage 2?
It ends with delivery of the baby, but is that when the dilation hit 10 and ends
It's
with
yeah, yep. It's our pushing part, right? Perfect. Good job. Which assessment of a postpartum client would be considered a normal finding 28 hours after delivery? Mm-hmm. Good. Where should her fundus be?
They say 28 hours, so technically that's a day, so it could be one finger breaths, but it's 4 hours into the second day, so it'll be two finger breaths.
All right. But so you have a general idea of where you should find it. That's perfect. The nurse notes a variable deceleration on the fetal monitoring tracing of a laboring client. Which action should the nurse implement first? Okay, first thing to do is reposition. What causes variable decelerations?
core
Core
compression?
compression.
Yeah. So if we reposition, hopefully we take some pressure off the cord. Okay. The nurse gives a 35-year-old prima gravida client a RhoGAM injection at her 28th week of pregnancy. Which of the following client situations require the nurse to take this action? Okay. So which moms need RhoGAM?
RH negative moms.
RH negative moms. Okay. Um, which moms are at risk of developing antibodies to, like, what does the baby have to have in order for the mom to have the possibility of developing antibodies?
Baby has to have positive blood.
Baby has to have positive blood. So if mom is negative, dad has to be positive in order for the baby to be positive. Okay, so that's why red is the better choice here. For blue, it is true mom's negative, but if the father's negative, then there's not going to be a risk of having an RH positive baby. In truth, we give RhoGAM to all moms at 28 weeks because we don't always know what dad's blood type is, and we don't always know who dad is, right? And so if they're RH negative, they get RhoGAM at 28 weeks. And then once the baby's born, we'll test the baby. And then we're going to know the baby's RH positive. And if the baby's RH positive, she'll get RhoGAM again. Now, if she miscarries, she'll get RhoGAM also, because we don't know if that baby was positive or negative. We don't know. All right. Clinical findings of gestational trophoblastic disease include all of the following except. So which one of these is not true? Okay, let's talk about this one. Does anybody know what gestational trophoblastic disease is? So gestational trophoblastic disease is a condition where the egg that is fertilized is lacking in genetic material. So it does not grow into a baby, but the body thinks that it's pregnant and the cells proliferate like crazy. And so with this, you'll see elevated HCG levels. Okay. Oftentimes with this, you will see hyperemesis. You can see high blood pressure. You can see vaginal bleeding because the blood that comes to the uterus doesn't go to a placenta and she can start having bleeding. Usually with this, the uterus will appear larger than dates because the proliferation of cells is much more exaggerated than if it were growing a baby. And so if you look back in your book, there's pictures of how it can look like a cluster of grapes on ultrasound or like a snowstorm pattern. And this oftentimes requires even like anti-cancer type drugs to stop the proliferation of cells.
So this is the same thing as a molar pregnancy? Is
Yes.
that okay, okay.
Yes, that is exactly what it is. It's a molar pregnancy. The nurse provides care to a client who's being prepared to receive an epidural blood patch for a post-dural puncture headache. In which position will the nurse place the client? Okay, so for an epidural blood patch, any idea how we do this or why we do it?
Is it for like a complication with the epidural?
Mm-hmm. Yeah. So when we place an epidural, we need to go into the epidural space, which is this kind of potential space right before the dura. And if the needle accidentally nicks the dura, then it can cause a leak of cerebrospinal fluid. If that happens, then it'll take a little while, so probably the next day, she'll start having like a post-dural puncture headache, where if she's laying down, she feels fine, but when she sits up, she has excruciating pain in her head. So what they can do for this is called a blood patch, and they take blood from the mom and they go back into the epidural space and they inject mom's blood into that space. Okay, so to do this, we're going to need her either to be side lying or she can sit and hunch over. Kind of one of those two positions is also how we place an epidural. We need to be able to access her epidural space. Okay, and then they put the blood in the epidural space and she almost immediately feels better. It acts as a placeholder. It doesn't continue to leak, and it saves that space where we're lacking from the leak so that her body can create more cerebrospinal fluid. And then after that, she feels better, like right away. What nursing action is especially important for a small for gestational age newborn? Okay, so let's talk about what small for gestational age is in relation to respiratory distress, because most of you picked respiratory distress syndrome. So remember, guys, the respiratory distress syndrome, the syndrome is caused by what? Anybody know?
What was the question? I'm sorry.
Respiratory distress syndrome is caused by what? It's a lack of something.
Surfactant.
Lack of surfactant. So which babies are lacking surfactant?
Premature.
Premature. And also our babies born to diabetic moms that have poor glycemic control. Remember, we had that kind of sidebar that can happen when those babies are making a lot of insulin. But most of the time, respiratory distress syndrome is seen in our premature baby. Our premature baby is not the same as a small for gestational age baby. A small for gestational age baby is a baby that is probably intrauterine growth restricted while in utero. And when they're born, they come out less than the 10th percentile for their gestational age. These are tiny little pumpkins that have a higher risk of hypoglycemia because they're lacking body fat and ability to stay warm and all of those things. Okay, so babies that are SGA or small for gestational age are less than 10th percentile, higher risk for hypoglycemia. That's actually also true for our LGA babies, large for gestational age babies. Those babies are greater than the 90th percentile, and they also have a higher risk of hypoglycemia as well. A baby is assigned, or a nurse is assigned to assist with caring for a baby born to a mother who is HIV positive. The nurse understands that each of these needs to be included in the plan of care except what? So which statement is not true? Okay, good. We don't have to put a baby that is born to an HIV positive mom in isolation. We just use standard precautions for that baby. All right. It is still taught that we are encouraging these moms not to breastfeed. I do know that in real life, if the viral load is 0, there are exceptions to this. But for NCLEX world, we're saying they shouldn't breastfeed. All right, so using standard precautions, encouraging moms to bottle feed, and then also administering the antiretroviral. Okay, and so this medication is given to the mother during pregnancy, it's given to her during labor, and then it's given to the baby after delivery to help minimize the risk of transmission of HIV to the baby. A nurse in the newborn nursery is monitoring a preterm newborn infant for respiratory distress syndrome. Which assessment sign, if noted in the newborn infant, would alert the nurse to the possibility of this syndrome? So basically, signs and symptoms of respiratory distress syndrome. Okay. Tachypnea and retractions. Do you remember? So respiratory distress syndrome and respiratory distress, like in the newborn, have the same symptoms. They just have different causes. So respiratory distress syndrome is from the lack of surfactant with our preterm babies, like we talked about. But other things can cause respiratory distress in the newborn, like meconium aspiration syndrome and inadequate fluid clearance and things like that, right? So signs and symptoms are going to be the same. And so tachypnea, fast breathing greater than how many breaths per minute?
$60.
Greater than 60. And then retractions, right, where it sucks in around the ribs or under the sternum. Okay. What are our other signs of respiratory distress besides tachypnea and retractions?
The seesaw,
Seesaw breathing.
Grunting.
Grunting.
nasal flaring.
Yeah.
Nasal flaring. Yeah. Okay. How long could a baby not take a breath and it would be normal periodic breathing?
Is it a minute?
It'll be
Oh,
less
that's too
than a
long.
Seconds.
minute.
Is it 10 seconds?
More than 10 seconds and less than
18
20
seconds.
seconds.
18.
20. It's 20.
Oh.
20. Yep. So Latoya's the closest with 18. So if we're less than 20 seconds that the baby pauses to take a breath, that's normal. If it's longer than 20 seconds, that's not normal. Okay. And remember, guys, that babies' breathing patterns are irregular. So they can have these pauses and then have compensatory breathing after that. And that's why it's really important that we listen for a whole minute so we really get an idea of what they're actually breathing. If I catch a baby right after they've had a pause and they're doing compensatory breathing, if I only listened for 15 seconds and multiplied it by 4, I might think the baby's tachypnic, but really it isn't. Okay, so that's why it's important to listen for a whole minute. To reduce the risk of hypoglycemia in a full-term newborn weighing 2,900 grams, what should the nurse do? Okay, of these choices, maintaining the infant's temperature above 97.7 degrees Fahrenheit was the best choice. Okay. Why is that important?
Because if they have hypoglycemia, they're cool, clammy, and yeah, the symptoms of hypoglycemia.
Okay. But the question is asking how to reduce the risk of hypoglycemia.
Keep them warm because if they're cold, they can't shiver. It burns sugar.
There
Well,
you
they
go.
don't shift.
Yeah, that's right. Yeah, that's right. They don't shiver.
Yeah, they can't
So they
shiver.
that whole cascade about non-shivering thermogenesis and how it contributes to hypoglycemia, right? Hypothermia and hypoglycemia kind of go together. All right, so keeping our baby warm above 97.7 is going to reduce the risk of having that non-shivering thermogenesis and having them develop hypoglycemia. Of the other choices, blue says assess blood glucose every 3 hours for the first 12 hours. That is something we would do if our baby was like large or small for gestational age or born to a diabetic mom, but not necessarily something we need to do if the baby is a normal weight and full term. Okay. We don't necessarily need to check the glucose levels. As far as encouraging the mom to breastfeed every 6 hours, how often should the mom breastfeed?
2 to 3.
Every 2 to 3, right? Good. So that isn't the best choice. And then feeding the infant glucose water Q3 until breastfeeding. Well, do we give babies glucose water? No,
Oh.
we don't. So the best choice for this question to reduce the risk of hypoglycemia is to keep our baby warm. A nurse is caring for a postpartum client who has breast engorgement following the decision to bottle feed her newborn. What should the nurse teach regarding relief of breast engorgement?
Well,
All right, so let's talk about this one for a second. All right, most of you selected supportive bra, and that is the best choice for this mama. Okay, the blue one, apply heat frequently to both breasts for 15 to 20 minutes. Heat is something that will help milk let down. That would be a great teaching tool for a mom who's breastfeeding. But for this mama who does not want to breastfeed, you don't want to encourage her to do anything that's going to stimulate her breasts, because every time the milk lets down, she's going to make more milk. Okay. And so the breasts fill with milk and get really engorged and really uncomfortable for a few days, and we need her not to stimulate them, and so the supportive bra is going to help, but we don't want to do anything that encourages the milk to let down. Okay. Now, if she was breastfeeding, we could have her manually expressing milk using heat, massage, like all of those things would be fine for her. But for a patient that doesn't want to breastfeed, we don't want her to stimulate her breasts at all. Six hours after birth, the infant is found to have an area of swelling over the right parietal area that does not cross the suture line. The nurse should chart this finding as... All right, we are very divided on this. Okay, how do I know that this is a cephalohematoma and not caput succedaneum?
Because it doesn't cross the suture line. I clicked the wrong one.
It doesn't cross the suture line. Okay, caput, guys, is superficial. So nobody can pronounce succedaneum. So when you see caput succedaneum, think that the S is superficial. Okay, it is something that is just swelling from pressure as the baby came through the birth canal. So it does cross the suture lines. All right, everybody know what we're talking about by crossing the suture lines, right? The bones of the head aren't fused, and so you have the fontanelles, and then you have the lines where the bones come together. And so with caput, it will overlap between more than one of those bone sections because it's a superficial thing from pressure on the head. A cephalohematoma is under the periosteum. And so the periosteum just surrounds each individual bone. And so the blood is going to stop at the end of that suture line. All right. And so if it says that it does not cross the suture line, cephalohematoma is what we think. If it does cross the suture line, caput succedaneum is what we think. Okay. What's the concern for a baby that has a cephalohematoma?
Jaundice.
Increased risk of jaundice. Okay, because with the cephalohematoma, cephalo is head, hematoma is blood, right? And when the body breaks that blood down, it's going to release bilirubin, which is going to increase the baby's risk for jaundice. A postpartum client calls the nurse into the room stating, "I just felt a gush of blood." The nurse notes a moderate amount of blood between the client's legs. What is the priority nursing intervention? Good. Fundus first. Okay. So we're going to assess the fundus. Is it firm? Is it boggy? If it's boggy, what should we do?
Massage.
Massage it. Okay. We want the uterus to contract and to control bleeding by contracting and squeezing those vessels. So we massage the fundus. All right. If we assess the fundus and the fundus is firm, where's the bleeding coming from?
Laceration or hematoma.
Yeah, it could be a laceration. All right. So assess the fundus first. Fundus is first. Okay. And then we can look for other causes if the fundus is firm. All right. Which of the following conditions would most likely cause vaginal bleeding during the third trimester of pregnancy? Good. So the green one is the only thing happening during the third trimester, right? A spontaneous abortion happens before how many weeks?
20.
Good. 20 weeks. So if we have a loss prior to 20 weeks, it's a spontaneous abortion. Gestational trophoblastic disease or the molar pregnancy, we're figuring this out very early on. Okay, we're not getting to any third trimester with this. And then an ectopic pregnancy is what?
When the egg implants in the fallopian tubes.
Okay, so we have our fertilized egg and it implants somewhere other than the uterus, usually in the fallopian tube. Is that going to grow to a third trimester? It would rupture the tube first. So of all of these, the only thing that's even making it to the third trimester is the placenta previa. What is happening with the placenta previa that can cause vaginal bleeding?
Is
The
is it
placenta detached from the uterine wall.
Not quite.
covering the cervix? No.
Yes.
Okay.
Yes. So placenta previa is when the placenta is low-lying and it covers either partially or completely covers the cervix. What is it when the placenta detaches from the uterine wall?
Albuterol. Albuterol.
Abruption is what you meant. Um,
Yes, and my daughter was laughing at me like, that's wrong.
it's always great when we're doing class from home and our kids in the background have an opinion about the things we're learning or teaching. My students or my kids have had opinions about it as well. Um, so I have boys, and my one son has listened to me teach this class for almost 6 years, and you'd be amazed at the things that he'll say because he just has learned so much. Yeah. All right. So an abruption is if it separates, all right, from the uterine wall, and then previa is if it's attached on the lower part covering the cervix. If I have a previa, how is a previa and abruption different from each other?
The
As far as
One
previa
is
covers the
painless.
cervix.
covers the cervix, it's painless,
Bright red.
bright red. Yeah, good. An abruption is going to be painful and dark red, and often if we put our baby on the monitor, our previa patient, the baby doesn't care, and our abruption patient, that baby cares because the blood that's supposed to be coming to the placenta it's not all going to baby. So then we can see late D cells as well. A nurse is caring for a 29-week pregnant client who reports lower back pain, lower abdominal pain, and contractions every 5 to 10 minutes. Vital signs are heart rate 92, blood pressure 138/86, temp is 100.4, respiratory rate of 18, and SpO2 of 98. What's the priority nursing action? Okay, what do you think the concern is for this patient?
Infection.
Mm-hmm. Yep, and infection can cause what?
Temperature increase.
Mm-hmm. And
Tacky.
mm-hmm. And
Hypotension.
how many weeks is she?
29.
Mm-hmm. An infection can cause preterm labor. So we've got a patient with a temp, an increased heart rate, increased blood pressure, and she's having lower back pain and lower abdominal pain and contractions every 5 to 10 minutes. So this could be a UTI, right? So the good first thing to do is to check her urine, all right? We're concerned about preterm labor for her. A patient at 32 weeks pregnant with severe headache is admitted to the hospital with preeclampsia. In addition to obtaining baseline vital signs and placing the client on bed rest, the physician orders the following 4 items. Which of the orders should the nurse perform first? Okay, for those that chose red, why did you pick this one as the first thing we should do?
Uh, well, to me, when I looked at the assessing the deep tendon reflexes, it was something you can get before you do urinalysis because it take a while. And when you assess them, you could check to see if it's like 2 and above or 2 and below. And if you see the clonus, and I think if it's how I'm trying to say it, if you do see clonus present, is that when it's a possible seizure? When it's present?
Mm-hmm.
Mhm.
Okay.
Mm-hmm. Yes. So the fact that, so assessing her hyperreflexivity is going to give us an indication potentially of how excitable her neurologic system is. And that is going to give us a sign of her seizure risk. Okay. So we can do a urinalysis to check for protein. We can do so urinalysis would be to check for protein. Baseline weight, we do keep track of their weight because remember, guys, that they hold on to a lot of fluid when they're preeclamptic. But we also check a complete blood count. What are we looking for with that? Do you remember? For preeclampsia, what in the CBC do I care about related to
The
preeclampsia?
platelets.
Mm-hmm. Good, the platelets. And I do want to know what her platelets are, but more important, when we're prioritizing these 4 things, more important is how excitable is her neurologic system. So checking the deep 10 reflexes and clonus is a good first thing to do. All right. Good job. A macrosomic infant is born to a diabetic mother weighing 45-50 grams, which is 9 pounds 6 ounces. The mother is successfully breastfeeding. The nurse's most appropriate action is to do what? Good job. Okay. We need to, this baby is LGA. Okay, this kiddo is greater than 4,000 grams. This baby is greater than the 10th percentile. This baby definitely would be at a high risk of having hypoglycemia, even if his mother was not diabetic. The fact that the mother's diabetic is even a higher risk for this baby to develop hypoglycemia. All right, the mother's successfully breastfeeding, so let's support that. All right. Always better if the baby is able to maintain their glucose levels with mom's breastfeeding, but we need to monitor it and make sure. So this baby will get heel sticks before each feed. All right. And then we're going to encourage frequent feedings. We don't need to give glucose gel. We don't need to give formula. We don't need to give IV dextrose as long as those glucose levels stay above 40. The nurse is caring for 4 infants. Which infant would have an increased risk of developing neonatal sepsis? Okay, prolonged rupture of membranes. Okay, what kind of infection typically happens during labor that can be caused by prolonged rupture of membranes?
Choreo.
Good. Yeah, chorioamnionitis. So when a mom has prolonged rupture of membranes, we have increased risk of chorioamnionitis. If mom gets infected, we have increased risk of sepsis for our baby. All right. Of these other choices, if we had a scheduled cesarean delivery, that doesn't increase our baby's risk of infection. And being large for gestational age doesn't increase our baby's risk for infection. Group B strep could increase our baby's risk for infection if the mom was not treated with antibiotics, but in this scenario, she was. So prolonged rupture of membranes is the concern. A client giving a medical history tells you she is in the early stages of pregnancy. Which of the following drugs should be immediately discontinued? All right, for those that answered blue, why is this the best choice? Liz, if you're talking to us, you're muted.
I'm sorry, I'm having debates with my daughter about my answers.
She's got an opinion. She needs to
It,
go to nursing school.
well, she want to be a vet.
Okay,
Yeah.
well, good for her.
It's used with inductions and stuff, so you would want to stop taking it because you want to maintain the pregnancy.
Correct. Why would somebody be on misoprostol when they get pregnant? Does anybody know what we use this medicine for outside of OB? So misoprostol is a medication that is prescribed for ulcers. And it's a GI medication. If you look it up in a med book, it's going to say it's pregnancy category X because it softens the cervix, it causes the uterus to contract. All the reasons that we do use it at the end of pregnancy is why patients in early pregnancy shouldn't use it. Okay. But it's possible for a woman to be on it and get pregnant. So if we find that that's the case, we should make sure she stops taking it. After assessing a pregnant client during a prenatal visit, the provider leaves the room and informs the nurse that the client has a positive Chadwick sign. Which of the following actions is appropriate for the nurse to take? Okay, what's our Chadwick sign? Do you guys remember?
It's the bluish coloring of cervix.
Yeah, good. It's the bluish coloring from the cervix and the vagina. What sign of pregnancy is this?
Probably.
Probable.
Good, it's probable. So if the provider says, yeah, she's got a positive Chadwick sign, he's saying that she has a probable sign of pregnancy, right? So she is at the prenatal clinic and he sees a positive Chadwick sign. That's normal. Okay, so there's nothing that we really need to do but to reassure the client. So remember, guys, that whenever you have something that you're finding is normal, the correct answer, your correct intervention is either reassure the client, document the finding. There's nothing to do. All right, so this is a normal finding. There's nothing to do. So we just let the client know, yep, that's normal. Nurse is working in an OB clinic and sees a client who's 27 weeks pregnant. Which of the following statements is the most concerning?
Mm.
Okay, good. It's getting harder to take care of the litter box. Why is that a concerning thing?
The
Toxoplasmosis.
toxoplasm. Yeah.
Good job. All right. Toxoplasmosis risk. So pregnant ladies should not be cleaning the litter box. All right. Shortness of breath in pregnancy, having some dyspnea is normal. Having clear or white vaginal discharge at 27 weeks is normal. Okay. And having a stuffy nose is also normal in pregnancy because of that increased blood volume, we can have some congestion, but we don't want them taking care of the litter box. A nurse is caring for 4 postpartum patients who each have an order for Methergin. Based on the data collected during the nurse's initial shift assessment, which patient would not receive the medication?
Blood pressure.
Good. Blood pressure. Okay. We're not going to give Methergin if she's hypertensive. Which of the following nursing actions is appropriate to prevent maternal hypotension following an epidural? Good. Yep. So we're going to give a fluid bolus before at the epidural to help support her blood pressure. A client is 250 and -2. She's uncomfortable and requesting pain management assistance. Which of the following pain control interventions would be most appropriate? All right. So where are we in the labor if we're 250 and -2?
She's too dilated, 50 in face, and -2 stationed. Mhm.
So are we in the latent phase or the active phase?
Latent.
Mm-hmm. And the latent is long. I mean, it can be, right? This is the part where it takes us a while to get to a point where our contractions are really effective and dilating our cervix well. And so at this point, using breathing and massage and walking and the tub and all of those non-pharmacological pain management things that we learned about would be great for her. Okay. Typically, we're going to follow a progression. So we'll start with breathing and massage, and as the pain gets more severe, then we can move to nitrous oxide or IV Stadol, and then ultimately get an epidural. Okay, so typically at this point, we would encourage her to do non-pharmacologic pain management first. A nurse is assessing 37-week gestation newborn born by scheduled cesarean section 4 hours ago. The nurse notes the following signs: expiratory grunting, nasal flaring, retractions, and respirations of 90 breaths per minute. The newborn most likely is experiencing what? Okay. Respiratory distress syndrome. What causes the syndrome? Respiratory distress syndrome. Lack of
Surfactant.
surfactant. Our baby's 37 weeks. Should they have sufficient surfactant? Yep. So not blue. Apnea of prematurity. First of all, our baby's not apneic. Second of all, is our baby premature? Nope. Meconium aspiration syndrome. It's possible that our baby has meconium aspiration syndrome, but this was a scheduled C-section. So probably not. Okay, it is possible with the scheduled C-section that we have meconium stained fluid, but usually not. Okay, this baby hasn't really had anything that could cause stress that could cause the baby to pass meconium. The more likely answer here is transient tachypnea of the newborn. And here's the clue, okay? Transient tachypnea of the newborn, they have a really fast respiratory rate and other signs of respiratory distress, and it's usually caused by what we call an inadequate fluid clearance, which just means, remember, that in utero, they're breathing all that amniotic fluid into their lungs. And if mom labors, during labor, the baby's body releases catecholamines that kicks the fluid out. And then the baby comes through the birth canal and gets a nice good chest squeeze. And all these things help clear that fluid. But for a scheduled cesarean delivery, we don't have any of that happening. So there's more amniotic fluid still in the baby's lungs when they're born. And it takes a while for the baby to work through that. And that causes them to have tachypnea. Okay, so if you have a scheduled C-section baby and they're breathing quick, greater than 60 breaths per minute, it's usually an inadequate fluid clearance and transient tachypnea. A pregnant client tells the nurse that her last menstrual period started on December 1st, 2018. When is her estimated due date using Nagel's rule? Okay, how do we do Nagel's rule?
Three months back, 7 days, at 7 days.
Hmm? Okay, and then add a year if we need to. And so if it's December, then we're going to back 3 months of September and then add the 7 days. So December 1st goes up to September 8th. Jane comes to the clinic for her prenatal appointment. She had twins at 36 weeks and a son at 38 weeks. What is her GTPAL? Okay, let's figure this one out. All right. Jane comes to the clinic for a prenatal appointment. So she's pregnant, that's one. She had twins at 36 weeks. That's one. And she had a son at 38 weeks. That's one. Okay, remember that twins count as one pregnancy and twins also count as one delivery. Okay, so we have 3 pregnancies. All right. Now, when we think about P1103, the P is para or parity, and the rest of the numbers is term, preterm, abortions, and living. So how many term deliveries has she had? the 38-week son, right? And then preterm babies or preterm deliveries. Okay, we still count one. All right, one preterm delivery for the twins. All right, abortions, none. And then living, she's got the twins and then the son. So living is 3. Okay. Everybody see that? I'm going to stop our recording here for this game.